Hello students, I am Dr. Debratna Mukhopadhyay of Department of Zoology of this college. Now today I will be giving you a lecture on the subject that is the parasitology that is included in your syllabus in DSE subject paper, DSE paper, and this will be having a brief knowledge about the parasite, about their host, and how this group of animal is causing serious problem to the mankind. Now first of all, I will be like to share the screen that this group of animal that causes malaria, that is the Plasmodium, the genus is Plasmodium, and it belongs to the phylum Epicomplexa, the class Coccidia, and order Hemosporidia. Now, regarding this group of animal, this Plasmodium have almost 50 species till date it has been notified, among which only 4 species of this group of animal causes malaria to human. These are Plasmodium vivax, Plasmodium falciparum, Plasmodium malariae, and Plasmodium ovale. Now, before coming to the life cycle, we will be having a short discussion about this malaria parasite. Now, these Plasmodium, which belongs to the phylum Epicomplexa, have includes two hosts. One is the human host and the other one is the insect host. Rather than these insects that actually propagates the disease are the female anopheline mosquito. That means the female mosquitoes are responsible for propagating this parasite. Now, like the Epicomplexan, the life cycle have 2 alternation of generation. One is the sexual phase and the other one is the asexual phase. Now, the asexual cycles that are termed as merogony usually occurs in the human host, rather than the sexual phase of this life cycle, that is termed also as gamogony, occurs mainly in the mosquito. Now, subsequently to the sexual stage and asexual stage, they are having alternation, and they if one of the phase is been cut off, then the propagation of the disease will be stopped. Now, once just concentrate on the figure here, you can see if the mosquito that is infected by the sporozoites takes a blood meal to the when the infected mosquito that is bearing the sporozoites within their saliva takes a blood meal to a healthy human being that liberates the sporozoites within the RBCs of the human being. Now, each of these sporozoites will be infecting each RBC. So, the point to be noted here is one sporozoite is infecting one RBC, and in this in a single bite, almost thousands and thousands of sporozoites that are liberated or that are inoculated within the blood of the human being will causing the infection within the RBCs. Now, these RBCs in first turn, they will be having 3 phases of within a human being. That is, one is the exoerythrocytic schizogony, then the erythrocytic schizogony, and the pre-erythrocytic schizogony. Now, first of all, we will be discussing about the exoerythrocytic schizogony. Now, by this name, the exoerythrocytic, that means erythrocyte means the erythrocytic cells or the RBCs. So, other than this RBC, if the sporozoite is infected other cell of the body, that here the other cell is the liver cell, then this cycle will be completed within the liver, infecting the liver cells, and this cycle is called as the exoerythrocytic schizogony. So here from this cycle we can see that after 1 to 2 weeks, the nucleus of the trophozoites having multiple fusion producing this rupture from the host cells, they enter the RBCs and via the blood circulation, and they is transformed into the erythrocytic schizogony. So this erythrocytic schizogony. Now from the liver cell, the erythrocytic schizogony will be started as they will be inoculating the RBCs of the fresh and healthy human being. Now this thing is called as the hypnozoites. So this is very important. Each of the sporozoites, when infecting the RBCs, there are certain names, and we call it by different names, such as first of this very peculiar name, that is the hypnozoite. So now this RBCs, when they will be transformed into the erythrocytic schizogony, here we can have a clear look that these merozoites interact with the RBC plasma membrane, giving the cell, and the RBCs will be having a large volume. You can see this is the large volume. They will be having a long that will be spreaded one, and the erythrocytes will be forming like a bulging balloon with lots and lots of cryptozoites within it, and that are multiplying itself by simply by binary fission, and they will be each of the erythrocytes will be laden with merozoites. Now when the merozoites are full within the erythrocytic cells, the RBCs, now these merozoites will be at time when it will be full, it will be bursting open, and then it will be ruptured, and now the this ruptured cyzons will be releasing the merozoites within the blood again, and each of these merozoites now in turn will be having their fresh set of RBCs, and they will invade there, and thus the infection will be carried forward. Now each of this cycle have a definite time. In case of Plasmodium malaria, it is about 48 hours. In case of Plasmodium ovale, it is 24 hours. In case of Plasmodium falciparum, it is 72 hours, and in case of Plasmodium malaria, it is about 24 hours. So each of this time span, this time span is very much species specific. So once the relapse of the fever, just by the rupturing opening of this cytons and infection of the fresh RBCs, this thing is very important, and each of these species have a specific time duration. So just by clinical examining the patient or having the history of this patient, this thing can be diagnosed in a by a very experienced doctor. Now about 80 to 90% of this cyzons will be liberating, and the cycle will be going on and on if the patient is not treated. Now 10% of these cyzons will having a gamogony cycle, and there they will be having the macrogametes like structure, one with a larger nuclei, that is termed as a female gametocyte, and one with the smaller nuclei that will be called as the male gametocyte. Now this male and the female gametocytes will be coming to the peripheral circulation of the human being, and they will be just waiting there for certain time, so that mosquito will be having their blood meal, and they will take this gametes within their body. Now this is a picture of an electron microscopic study. You can see how the RBCs are laden within the cyzons. the merozoites, and this is the when the RBCs are ruptured open, the merozoites are liberated out, and they are capable of infecting the other RBCs. Now, before this, macrogametes and the microgametes, they will be in the peripheral circulation, and they will be waiting for a mosquito, female mosquito, to suck them up. If not, they are sucked up, then what will happen to them? This thing may come into your mind, that what will be happening then, ma'am? Then only after 6 to 8 hours of their formation of these gametocytes, they will be automatically dissolved within our body, and they will be no more capable of spreading the disease. So this is a very vital point of the for combating this disease, that if a person who is already infected with this malarial parasite, if he or she is kept under certain environment, that no mosquito can come and bite him or her to take the blood meal, and then these things cannot be propagated from one to another. So this is a point to be remembered by you, that the patient, when it has been identified as a infective one by malaria, so he or she might be kept in a secluded portion, and he or she must be kept under the mosquito net, so that no mosquito can come and take the blood meal from him or her for the next propagation of their cycle, that is about that should be within the mosquito body. Now, in the mosquito body, what happens here? The sexual phase actually occurs. Now, the blood meal, when it is taken by the mosquito, they take both the macrogametes and the microgametes within them. Now, these macrogametes and these microgametes undergo maturation process, that is called as the exflagellation. You can see in the picture number 9 is this, you can see in the picture that the macrogametes are having the exflagellation, and the macrogametes are here. So just like sperm production, the flagellation do occur, and in case in the macrogametes, they are their size is much larger, and they are stationary. Now, in case what happens, the nucleus here undergoes 3 mitotic divisions. So they have to attain n number of nucleic material, so they have to undergo the mitotic divisions, 3 mitotic divisions, producing 6 to 8 nuclei that migrates to the periphery of the gametocytes. Now, accompanying this nuclear division, there are certain centriolar divisions, following which one portion joins each nuclear segment to become a basal body, providing the center from which the axoneme arises. Now, the nucleus with the axoneme and a small amount of cytoplasm from the microgametes that detaches from the mass and swims to the macrogametes, just like the in case of higher vertebrates, the sperm swims towards the ovum. Here also the microgametes swims towards the macrogametes. Now, during this periods, the macrogametes have developed into macrogametes, and that has been penetrated by the microgametes. Now, the fusion of the male and the female pronuclei, that is termed as syngamy in case of protozoan reproduction, produces a diploid zygote that elongates into the ookinete. Now, this ookinete now penetrates the gut wall of the mosquito to the area between the epithelium and the basal lamina, where it develops into a rounded oocyst. Now, these terminology are somewhat new to you, that what is ookinete, what is oocyst, and so on. So, you must concentrate on each of this terminology that we are discussing here. Now, growth of this oocyst is in part due to the proliferation of the haploid cells, that is called as the sporoblast within the oocytes. Now, this sporoblast nuclei undergo certain nuclear divisions, producing thousands of sporozoids, which is enclosed within the sporoblast membranes. As the membrane ruptures, the sporozoids enter into the cavity of the oocyst. Now, the sporozoids filled with the oocyst themselves rupture again, releasing the sporozoids in the hemocoel of the mosquito. These sporozoids then are carried to the salivary gland duct where the insects and are ready to be injected into the next victim, which they visit for their next blood meal. Now, here in this picture you can see that this is the longitudinal section of a mosquito intestine showing numerous oocysts that are lined within the intestine. Okay, so these are the longitudinal sections, and you can see within the intestinal covering that the oocysts are positioned here, and these are the sporozoids that are isolated from the salivary gland of the female anopheline mosquito. Now, here is a differential chart of the 4 types of species that are infecting the human being. Now, first of all, the very common one that is we are discussing about, that is the Plasmodium vivax. Now, and then comes the Malaria, then the ovale, and lastly we are concentrating on the Falciparum. Now, the diagnostic differences, we will be concentrating on the duration of the schizogony. That means what I told you in my previous slides, that the cell RBCs, when they are laden with the schizons, they will be liberating, and these schizons are now capable of infecting the fresh sets of RBCs. Now, this time duration is very species specific, and I have told you that they are very species specific. So, you can see the duration of the schizogony is 48 hours in case of vivax. In case of Malaria is 72 hours. In ovale is for 50 hours, and in case of Falciparum plasmodium, that is Falciparum, that is about 48 hours. Now, these are the motility chart you can see. Then the pigment which are associated within the RBCs, we can see they are fine yellowish brown and fine granules with minute rods in case of vivax. In case of Plasmodium malaria, we can see the dark brown to black. So, the color varies from this to this. Again, they are very much common, these two, malaria and ovale, are very much close in color, but only the color is that this is dark brown to black, and here we can find it only dark brown, and in experienced eye this can be distinguished only. In case of stages that are found in the peripheral blood, we can find the trophozoites, the schizons and the gametocytes. Whereas in case of Plasmodium falciparum, we can see that only the trophozoites and the gametocytes are found. The multiple infections are very common in Plasmodium vivax as well as very common in Plasmodium falciparum. When we go through a slide preparation of this blood slide preparation of the human blood, we can find that there are certain forms, that is the trophozoid forms, schizons forms and gametocytes form. By analyzing these forms, we can also say that in pathologically which one is which, that can be easily diagnosed. Now, in case of vivax, we can find the amoeboid phase, we can find Schuffner's dot, we can find the ring stage, and rather than these things are not much common in these two, plus in case of Plasmodium malaria as well as in Plasmodium ovale, but very small and large rings of vacuoles are very common with 2 chromatin dots in case of Plasmodium falciparum. So again, there is a point that in very experienced pathological eye can distinguish this blood smear from one to another. Now, in case of segmented scisons, here we can see the RBCs are filled largely with about 12 to 24 merozoites irregularly arranged with pigmented mass. Whereas in case of malaria and in case of ovally, only 6 to 7 normal sized RBCs are found, and they are having some centric or eccentric pigmented mass, which is absolutely not common in case of Plasmodium falciparum. In case of when we are talking about the gametocytes, we can see that the Plasmodium vivax here, it is round filled, the RBCs, chromatins are undistributed in cytoplasm. Whereas in case of the falciparum, we can see that the crescentic or kidney shaped and the chromatin is undistributed in the cytoplasm. Now, this is a pictorial view of the Plasmodium vivax. These things, this is the ring stage, the amoeboid ring stage we can find, and these are the Schuffner's dots present, the pigmented dots are present. These are the scisons, fully laden scisons in the RBCs when they are liberated. So this looks like this, and then these things are we can find in the blood film. In case of very common place of incurrence, that means in when there is a endemic place, we can find that only a thick smear can be able to distinguish whether the patient is having the malaria parasite or not, just by having a thick smear of blood on the slide when there is absolutely no occurrence of microscope and there is no other equipmental help. So this is about the picture. You can easily go through, and there is the what actually happens and what are found here. This has been liberated. This has been mentioned here. This is a picture of in case of Plasmodium ovale, that is called as the Tarsian malaria. Okay, so by comparing the previous picture and here, you can see the RBCs are somewhat they have been distorted, and only 3/4 portion of the RBCs are filled with the scisons. Now coming to the quaternary malaria or the Plasmodium malariae, you can see that they are distributed in the periphery, and then after liberating, they will be looking like this. And obviously, in case of when we are having a comparative study of Plasmodium vivax, malaria and ovale, we can see this clear picture, and you can obviously you can have a look, and this is the thing that is very much uncommon in this phase of life cycle, that is the Siemens dot. In case of Plasmodium vivax, we can find the Schuffner's dot, but whereas in case of Plasmodium malariae, we can find the Siemens dot. The hemozoins granule that appears in the center of the periphery of the scisons. Those trophozoites bear as a band, and the mature trophozoites resembles that of the macrogametocytes. Now coming to the last or very important one, that is about the Plasmodium falciparum. Now this is also termed as the malignant Tarsian malaria. Now the term malignant is very much having very much fear creating word, that is the malignant. That means it is silently growing within your body, and even it will be coming to final stage, then only it can be diagnosed. And when it will be diagnosed, there is almost very less time to cope up with the disease. What happens in case of this falciparum malaria, Plasmodium falciparum, the trophozoites having active amoeboid, they will be having chromatin dots and amoeboids, so they cannot be they cannot be diagnosed through a thin blood spleen, and then when they will be diagnosed, it will be almost clogging the arteries and venules of the human being that is serving the blood supply, and so thus the death rate is very much high in case of this Plasmodium falciparum. Now you can see that they will be having almost same features like that of the vivax, but rather than they will be having absolutely no typical structure like that Siemens granules or Schuppner's dots and so on. So when we will be finding it in the thin smear in an inexperienced eye, that can be missed out as Plasmodium vivax. But in case of experienced eye, these things can be noticed, and these scisons, when they are liberated within the RBCs, they will be looking like this. So only in case of experienced pathologists, they can be distinguish the falciparum as well as that from the vivax. Now, this was all about the comparative studies of the 4 Plasmodium species. Now we are concentrating on the epidemiology. Now this term epidemiology, what does it mean? Epidemiology means the occurrence of the disease in a place. Now in case of this malarial parasite, there is distribution is confinedly on the mosquito population, where the population of this Anopheline mosquito is higher, then that area is thought to be as prevalent of these diseases. The local environmental factors having particular species of mosquito that transfers, the local epidemiological surveys can be used to assay this and prevent the vectors. So it is better to kill a mosquito than kill a human being which is having the disease. So in the very first of few slides, I have already discussed you that how the population of the propagation of this disease can be stopped, not on just to not to allow the mosquito to bite a human being. Okay, now precipitating tests of the indigested blood from the infected mosquitoes reveal whether the vectors are zoophilic or anthophilic feeding preferences. Now, water dependency for the breeding varies very greatly. So, obviously, you all know that where the water is logged in somewhere, the mosquito takes a privilege to breed on that ground. So it is very obvious that we should be very careful of not allowing the water to stand anywhere. So this will be having a better breeding ground for the mosquitoes, and they will obviously the fresh brood of mosquito will come to visit the human being that has been infected, and then the infection will be going on and on. Now the control of this malaria depends on varieties of factors such as availability of the antimalarial drug, uses of screens on house to keep out the mosquitoes, proper use of insecticides, elimination of mosquito breeding sites, etc. So this thing we should keep in mind, that the malaria can be controlled in this several steps. Number 1 step is the uses of anti-malarial drug that are very much common, and this is very readily available, low cost, and having less side effects. The doctors usually prescribe certain anti-malarial drug, and that should be taken in a solid regime. Now, use of the screens on the house to keep out the mosquitoes. So we should be keeping in mind that the control of malaria actually depends on certain factors. Number 1 factor is the availability of the anti-malarial drug. that is a low-cost drug widely used and prescribed by the doctors, that are found in that is available in all the medical stores, and it should be taken in a fixed regime as the doctors has been prescribed. Now the second one is the uses of the screens on house to keep the mosquitoes away from it. So if it is possible to use the mosquito nets or the mosquito screens on the doors and the windows to avoid. If not possible, so we have to, as we know that the mosquitoes have certain points, certain time of visit to the human population. So if it is possible to close the doors and the windows just before the onset of the evening, so as to control the mosquitoes from coming from the outside to the indoor and have a bite on us or have a blood meal from the healthy human being. Now the third one is, last one is the proper uses of insecticides. Obviously, what we have to do, use to some mosquito repellents that might be in the form of coils, that might be in electrical repellents, or use of any ointments or droplets that should be sprayed or sprinkled around you or our houses. Now the very important one is the elimination of the mosquito breeding sites. Now if we have a common practice of storing the water near in our houses, in the gardens, in the pots and earthen pots, or in the outside one, we used to store. If not also we have this habit, we can see that the leftover tires, tubes and so on, and some puddles or the drains which are uncovered, they are also citing a good breeding ground for these mosquito group of animal. Now we can see world picture, which one we can see the prevalence of the mosquito, and obviously the cross marks are the chloroquine resistant portions, and other one is chloroquine sensitive, that is the dark fields are chloroquine sensitive malaria. So this is about, you can see that the distribution is almost along the 30° north to 30° south of the equator. The distribution of this mosquito and this plasmodium is been seen. Now coming to the next slide, we can have a close look, a very close look, that the relapse of the infections. Obviously, if we do not take the medicine, if that has been prescribed by the doctors, the infection will be coming and coming again. Now the victims of the vivax or the ovally may suffer a relapse. Originally what happens, the relapse was thought to be due to the population of the cryptozoites being maintained in the exoerythrocytic cycles. That means if the medicine is not procured, so the pre-erythrocytic schizogony will have liberating the fresh sets of schizons from the RBCs. Now while one population is progressed to the usual erythrocytic phase that underwent the schizogony and released the merozoites into the circulating bloodstream, causing the malaria, the other population maintained an ongoing exoerythrocytic cycle known as para-erythrocytic cycle. So this is very important one, that is the para-erythrocytic cycle. Now the parasites in the hepatic stages, that means that are already lodged in the liver, the cycle were thought to be protected from the host antibodies until activated by some physiological changes within the host that allowed them to erupt from the hepatocytes, precipitating another bout of malaria. Now, in a more recent view, it has been seen that the existence of two different populations in the sporozoites. One is the short pre-patent sporozoites and other one is the long pre-patent sporozoites or the hypnozoites. Now, in case of the short pre-patent sporozoites, upon entering the human host, these sporozoites undergo usual exoerythrocytic and the erythrocytic phases of development that causes the malaria. Whereas in case of the hypnozoites or the long pre-patent type, it remains dormant in the hepatocytes for an indefinite period. So this is very important, that the hypnozoites usually remains dormant within the hepatocytes in the liver cells, and if not treated, from these liver cells the sporozoites will be liberating and a fresh bout of malaria will occur. Now, the recrudescence in the recurrence of this malaria among the victims are affected by the Plasmodium malariae. Each year, after apparent cure fostered in the species that produces the relapses that are produced by the Plasmodium vivax and the ovary. But it has been shown that the periodic increase in numbers of parasites actually results from a residual population persisting at very low level in the blood after inadequate or incomplete treatment of the initial infection. The situation may persist for as long as 53 years. So, if a person is once infected and if there is no medicines that have been procured, so in an experimental case, we can see that this thing might persist up to roughly 50 years before sometimes it triggers a parasite population explosion with accompanying disease infestations, and this phenomenon is referred to as recrudescence. Okay, now coming to the almost to the last part of my discussion, that is about the symptomology and the diagnosis. Now, what is symptoms? What are the symptoms, and by which symptoms we can say that the person is infected with the malaria? Now, the pathology of the human malaria is generally infested in two basic forms. One is the host inflammatory reaction and anemia. The host inflammatory reactions are initiated by the periodic rupture of the infected RBCs, which releases the malarial pigments as the hemozoins and the parasite metabolic wastes. Now, synchronously, this rupture is accompanied by the fever that is called as the paroxysm. This might sometime come into your questions, that what do you mean by the paroxysm? Paroxysm is nothing but when the rupture is accompanied by fever, that is usually synchronous except during the primary attack, is called as the paroxysm. Now, during the cell rupturing, the toxins are also released, which in turn causes the macrophage cells to release the TNF, that is the tumor necrosis factors. It's the TNF that actually induces the fever. So, not only by just the rupture, the TNS actually induces the fever by rupturing some of the macrophages releasing within the blood. Now, during the primary attack, the synchrony may not be evident since the infection might arise from several populations of liver merozoites of different stages of development. Now, when we will be talking about the macrophages, particularly those in the liver, bone marrow and the spleen, the phagocytose release pigment. In extreme cases, the amount of pigment is so great that it imparts a dark green, reddish brown hue to the visceral organs such as the liver, spleen and the brain. With increased RBC destruction accompanied by the body's inability to recycle iron bound in the insoluble hemozoin, the anemia is developed. Now, the TNF toxicity may also induce the splenic removal of the unparasitized RBCs and inhibit the bone marrow production of the new RBC. One pathological element that's unique to the Plasmodium falciparum vascular obstruction is very common, and this release the TNF toxicity may also induce the splenic removal of the unparasitized RBCs, and they inhibit the bone marrow production of new RBCs. Now, one of the pathological element that is very unique in case of Plasmodium falciparum is the vascular obstruction that usually causes the blood veins and the arteries clogged, and that results to an instant anorexic condition that terminates in the terminal cases. It blocks the capillaries in the brain that in that case it is also called as the cerebral malaria. And as because the venules and the arterioles that are supplying the veins are clogged, and the anorexia takes place within that part of the brain, which will be having a seizure in the brain, and the patient may succumb. Now, in other case, it is also called as the black water fever, as because the malaria, this parasite is found to be in case in the water where there is toxic water and the water turns black. Now, this was previously in case of the in the Egyptian culture also we have seen this black water fever. In this case, in case of falciparum infection, fever, vomiting with blood, jaundice may also occur. Hemoglobin level certainly comes down, and the mortality rate is very high, rather than 20 to 50% is mortality rate. That is usually due to the renal failure and due to renal anoxia. The exact cause of this condition is uncertain till now, and that it may be a reaction to quinine, or it may form an autoimmune phenomena in which the hemolytic antibodies are produced in response to the chemotherapy. Now, the drugs that are used to treat this disease in the human, as well as the continuous effort to control the mosquito population, the first and very popular drug is the quinine. Now, this drug that primarily destroys the schizogonic stages of the malaria. The synthetic drug atabrine dihydrochloride has proved to be successful against the erythrocytic stages and in suppressing the other clinical stages. Some other drugs, synthetic drugs, has still been used. That is, one is the chloroquine, amodiaquine, and the primaquine is the most common thing that has been used and very popular among the doctors and the physicians. Now, with the addition of this chemotherapeutic results, it is very the researches are still been going on for the invention of the vaccine against the malaria. Interestingly, it is seen that the surface coat of this trophozoite act as a renewable decoy to the vertebrate host immune system, stimulating the production of the antibodies. When the sporozoite is attacked and its decoy coat is sloughed off, a replacement coat is synthesized, and its decoy effect remains continuous. This system provides an ideal protection for the sporozoite, which only spends a brief amount of time in the blood before it penetrates a liver cell, as it is protected by the circulating antibodies. In case of the endemic areas, the premonition is the basis for the protective immunity as long as low-level infection persists. However, with complete cure, the victim regains the susceptibility. Now, also the nursing infants in endemic areas are protected through the antibodies in their mother's milk. They are at risk at the time of the weaning. So, this is a very important thing, that the babies which are having their mother's milk are somewhat protected with the antibodies. In case of falciparum, Plasmodium falciparum, it has been seen that only this can cross the placenta and cause the infection in the fetus. So it is very important to note that only the Plasmodium falciparum can cross the placental barrier and infect the fetus. Now, several genetic conditions are also known to affect the malarial organisms. Susceptibility is conferred to the presence of Duffy antigens, that is the bivalve merozoites penetrations of the RBCs requires one of the two Duffy antigens that are very common in the South African population. Genetic deficiency in G6-PDH activity in RBCs creates the inhospitable condition environment for the parasites. The human heterozygous for sickle cell anemia possess a selective advantage over the individuals with normal hemoglobin in region where the Plasmodium falciparum is endemic. So this is all about today's lecture regarding the malarial parasite and the comparative accounts of the 4 species that are found to be infectious to the human being. So thank you.